And good afternoon. Good afternoon to you. My name is Dr. James Smith, and welcome to the Dr. James Show. Thank you for joining us again for our show. We're looking forward to providing information and transformation as we always do. This is our second to the last show for the year, so our goal is to finish strong. And we believe we have just the show for you today. Before we move forward, though, let's bring out our sponsors. Our host is Rachel Barkley, the general manager at the Pyramid Club. Rachel, happy December 22nd. How are you?
I am well. How are you?
I'm doing good. I'm doing good. The year is winding down. Hope is on the way. People are feeling more festive now and focusing on intimate gatherings with family and loved ones and friends. So I'm looking forward to that. With that said, though, Rachel, rumor has it that you guys have some pretty cool things planned for the rest of the year, as well as this mojito I'm hearing about. What's that about?
Mojito, you must be in island time. I would love a mojito, but we're doing coquito. Speaking of a strong finish. Coquito is like a Puerto Rican eggnog. They make it in Mexico too, called a different name. But it's like coconut based and it's delicious. Lots of rum. It is not a virgin drink.
And you just happen to be an expert in making those?
Well, I like to become experts in things. So I wasn't prior to doing this, but after working on it for a week, I had drinking. Unfortunately, if you work with me, you have to try cocktails. So,
Right.
so now we're experts here at the club.
Well, I believe in multiple sources of income, so you may need another taster in 2021. So I'll keep sending you those emails, knocking on your door. What else do you guys have in store for the rest of the year? Some of the things you're doing.
Well, I feel like I've been in 2021 for like 2 months now, but that might be wishful thinking. We're ready to leave 2020 behind us. We learned all of our lessons. We're taking this time to reflect and getting ready to really, really start 2021 strong. So thank you for hosting this show. We've been happy to sponsor in this entire year too.
Absolutely. And I look forward to you not only during the beginning of next week's show, but actually being on as one of the panelists as we're doing our celebration alumni show, bringing guests back to talk about empowerment, talk about lessons learned, and what they intend to do going forward in 2021. So looking forward to seeing you next week.
Yeah, thank you.
All right. Time for me to bring out my co-pilot. I do not take off without her, Shannon Peck. Shannon, welcome back. Get ready to take off and soar again.
Can you believe we're here again already? I'm excited.
It flies by. Each Tuesday just keeps getting here really quick.
I know. I'm telling you. Well, I just want to encourage the guests today because the folks who are joining us to make sure today, more than any other time, please don't be shy. And welcome back, those who join us each week, and those of you who are brand new, welcome. But there couldn't be a more timely guest in everything that's going on with today's climate. So I'm really excited, Dr. James, to get started today. And make sure you light up that chat room with all of your questions. This is an opportunity to ask the things that you want to ask, something you're not so certain about, things you need clarity on, all things COVID and health related. So super excited.
I'm especially excited for this show because I've watched news, I've watched panels, I've seen videos, but I did not participate in asking those questions. I had to patiently and passively listen to the information that was being shared with me. So knowing that I play a role and you play a role today in asking those questions and learning more about this pandemic that's been trending, that's been around since March. So you ready to dive in?
Yes.
All right, our guest for today, let me read just a little bit of his bio because he has accomplished a lot in a short period of time. Dr. Gregory Peck, DOFACS, is an assistant professor of surgery at Rutgers Robert Wood Johnson Medical System, an assistant professor of health systems and policy at Rutgers School of Public Health. He's also a trauma surgeon. He's also a husband. He's also Kennedy's father and Harley's owner. Let's bring out Dr. Gregory Peck to the show. Doc, what's up?
Hi, thank you so much for having me today. It's a pleasure to be here with you.
It's our pleasure, it's our honor. We have a specialist who's going to help us put some of the bridge the gap with our uncertainty and ambiguity. And so I'm glad you're taking the opportunity to be with us. But I want to jump in right away. Let's go back to March. Go back to March when this started trending and people started working from home and things closed and the hospitals filled. Where were you? Mindset, physically, where were you when this started to happen? This being COVID-19.
I think if you were to put this in context, starting with March, I was probably 2 months, in the medical field, in public health. We were about 2 months ahead of the general population, understanding what potentially was coming, and how serious it was. And I was in preparation mode as a trauma surgeon, which we may talk about a bit later on. Yeah. But I was preparing for the worst, and knew as an ICU doctor that the worst was going to come on my front lines and my colleagues' front lines.
When you say the worst, what does that look like? What did that feel like when you said you were preparing for the worst? What were you preparing for?
Well, to sort of put it in the way that I can easily think about it, as a trauma surgeon, there's mass casualty, or an event that 5 to 10 to 15 people are all injured at the same time. Let's say maybe a bus accident, or even worse, some type of act of terrorism or violence. 5, 10, 15 patients come to you at the same time, and you're triaging the volume that's about to come to you at the healthcare system on the front line. But we understood that what was happening in other parts of the world, we were not talking about 5, 10, 15 people at a time. We were talking about hundreds at a time, and hundreds requiring the highest level of care, the most intensive care, with all of the machines possible, with all of the providers responding to this population that was about to come to us.
I know you're skilled in this area. You schooled, you've done your residency, you've been at this for a long time. Mentally, though, and emotionally, how do you prepare for this? I mean, I know they tell you it in school, but how did you prepare, knowing that you were 2 months ahead of everyone else?
It's an interesting question, because I think this year for me has been transformative in a lot of ways. I think professionally, personally, all transformative, and right around that time where we were being introduced to a pandemic that we would all experience probably once in our lifetime. There was a lot of good things going on in my life as well, which was an interesting balance, because of all of the catastrophic events around us. There was good things that were happening too, as I said, personally and professionally. So trying to put those things in balance, and understanding that as a clinician, as a surgeon intensivist, and maybe we'll get into my background a little bit so I can explain exactly what that meant with respect to the first wave of the population coming to us. I was preparing for the worst clinically and emotionally, because I knew how much that was going to really require from the clinicians in the US. But at the same time, professionally, from a research perspective, I was thinking for the first time about, a question that I wanted to ask for the first time and answer through some more advanced types of studies that I just finished with a public health degree. So it was ironic experiencing both things, an emotional high, perhaps an emotional low at the same time, and trying to balance that to move forward for the population that I serve, but also for me personally and my family.
I was going to ask you that, what did that mean for you this year from a family perspective? But it sounds like there's been a balance of professional and personal. But also, let me ask you this, with you, I'm assuming since you were front line, you were away for hours, working triple time. How did your absence impact how things continued with you and your family during this time?
So that's just the thing, Dr. James. I first want to acknowledge all my colleagues, and frankly, some of the younger colleagues, and frankly, the surgical residents and the medical residents, and also the advanced practitioners, who are advanced trained nurses, physicians assistants, all the physician extenders. They sometimes are referred to in the general population, but all of those people that were on the front line, in addition to me, I just want to acknowledge for a minute, because the shifts were 24 hours a day, 7 days a week, extra shifts, double shifts, sort of triple staffed at times from what we were originally seeing in January and February prior to March. The way that you've put it in March 2020 was sort of the introduction to all of this for us. And at the same time, for me, that was a professional shift, where I wasn't participating in as much clinical care as I had in the past, which, if I'm shifting that way from what I was doing clinically, it was right on, because what I was doing also in my studies was shifting toward understanding some of the public health and policy crises that pandemics like this bring. So I was participating in a different way, not as much as my colleagues on the front line, 24 hours a day, 7 days a week. However, to answer your other question, being home from after the time I worked, putting myself in quarantine and keeping myself and my family safe by living on one side of the home where my wife lived on the other side of the home, we did that for a good 2.5 months. So there are aspects of what emotional balance I had to work with my professional work, but also my family life.
Thank you. Thank you. Dr. Peck, how did we get here? There's so many different stories and anecdotes and blame going around, but how did we get to COVID-19, get to the panic, the pandemic, and tell us more about what this virus really is?
I think it's a culmination of what's been happening all along. So I think the biggest thing for me as a clinician that also has now had some training in public health and policy, it is an example, and it's the 100th example of how the health system and the hospital system address sickness in the population. I think COVID has exposed certainly some of the weaknesses, but also some of the strengths of the health system and the public health system. And I think we've gotten here because we have finally met something, unfortunately, that exposes everything at the same time, but also in some hope here, allows us in many of the different fields that are responding to this, also allow us to have hope in a new way, where COVID has exposed certain things that I think now the public and also the healthcare profession are on a different, they're having a different conversation across the table at Starbucks, for example, where it's connected some of what the issue is in healthcare in the United States of America. And I think COVID is the biggest example of all of it at the same time, to sort of have us all open up the same eyes, no matter what walk of life we're in.
You started answering one of my questions that I've written down, and that is, how is the COVID-19 pandemic both a public health system crisis and a hospital health system crisis? Let's just start there before I ask the follow-up question. So how is the COVID-19 pandemic both a public health system crisis and a hospital health system crisis?
Well, in the United States of America, we like that the health system has historically been very siloed. And what I mean by that, to answer your question, is there's either inpatient hospital care, or there's these other things that can be prevented way upstream. And all of, heart disease, obesity, diabetes, hypertension, or high blood pressure. These are examples that I think we're familiar with in the public of these chronic health conditions, but there's a little bit of a silo within the healthcare industry, that being big pharma, the hospital system, just meaning the facilities, the hospitals. And then there's this other entity where you have several pieces of what's necessary for a population, for example, a state, New Jersey state, to be taken care of, or the state of Pennsylvania to be taken care of. And those thinkers that address that type of approach to caring for the population, and in other words, caring for all of the people in a state with diabetes in a systematic way, that is the public health professionals, that is the policymakers, that is the researchers, that is the NIH, to put it in perspective of what's in the news. That is Dr. Fauci, for example. Right. And I think in the United States of America, with the exception of very creative, innovative, culturally proficient health systems that link with the public health specialists. With the exception of those very, very few health systems and state systems in the United States of America, we remain very separated. So what I mean by a public health crisis and a health system crisis is that COVID-19, it has affected every single part of the population. Certainly aspects of the population to a larger extent, which I think we're going to touch on, but it's touched every part of the population, no matter who you are. And it also has affected the clinicians that work inside the hospital, because at that point, there's a good portion of the population back in March that was so sick that despite all of the expensive healthcare, despite us being there 24/7, it was a little late because of those upstream, that public health gap where the population is addressed in a certain way, so that then it doesn't impact the hospital health system in such a significant way that you don't have both crises at the same time. And the pandemic has been that unique combination of a public health crisis where we care for the population before they're sick, and then the hospital health system crisis, which we then care for the patients when they're sick. It's all happening at the same time.
Wow. Thank you, Shannon. Why don't you join in on this conversation? It's heating up. It's heating up.
It is. We have a guest who wants to know, not sure, Dr. Peck, if this is a question for you, but he spent more than 30 years in big pharma, and he has heard many talks about drug discovery process and why it could take more than even a decade to bring a drug to market. Why should we trust this vaccine that has come to market in less than a year? That's the question out there.
That's a tough question, because I know, now so being on a public show, it's a different answer depending on, I think, what perspective I'm looking at it from, a clinician, a public health researcher, a potential policy creator, or a husband or a father. And that's what I'm getting in touch with in this stage of my life. So why should we trust by the way, I'll put this in context, the question. As a frontline healthcare worker with the highest risk, I'm eligible for the vaccination as tier 1A, as you guys may see it referred to in the state of New Jersey. And so when I move forward with getting vaccinated, one of the steps is signing a release saying that this is a non-approved experimental drug that the FDA has said to move forward with. And it was the first time I actually read that language, knowing that this is in fact an experimental drug to some extent. And what we're to go by is the evidence right now. And the evidence suggests, and I want to make this differentiation to answer the point that the caller or the chatter, so to speak, has raised. The difference with the COVID-19 vaccination is it has been proven to be safe, which means it hasn't harmed any of the persons participating in the studies. And it's also been proven to be efficacious, which means that it does what it's intended to do. The one thing that the COVID-19 vaccination hasn't been proven to be just yet is effective. And you'll hear it because I think it's a misnomer, but you'll hear that it's effective. It's not effective until it makes its impact in the population, in the real population, right? And so I think we can trust the evidence that it's safe. I think we can trust the evidence that it's efficacious with very minimal side effects. But what I'm really interested in is it effective? Is it going to make its impact in the population that in a way that we're intending it to? So I trust it because of the evidence, and the evidence says that it's safe and efficacious, meaning it's not going to harm me to a great extent, and it doesn't outweigh the benefits. The risks do not outweigh the benefits right now, given that it's a pandemic. That's what the evidence suggests to us. It's not hurting anyone, and I'll stop there.
And Dr. Peck,
Thank you. Shannon, what else is going on out there?
Well,
I was saying, what else is going on out there?
Oh, well, I also wanted to ask, is part of the dynamic of this being so effective is that they did put worldwide so many resources and so much money and time and effort onto it as a priority, potentially over other things that maybe the NIH and the epidemiologists were working on.
I think, yeah, I think again, it's safe. It's been proven to be safe and effective. I'm sorry, safe and efficacious, not effective, because we haven't seen what it's doing in the population. So just making that point again, I think, yes, there's been tremendous amounts of money invested, but more than that, I think what's really been fascinating to me is that we were still able to achieve what we've proven the vaccination to be, safe and efficacious. But we've done it in such an expedited manner. It proves to me, and it proves to the scientists out there, that it is possible. It is possible. And I think what gets, to some extent, in the way sometimes is not the consideration for the population. And I think in this particular case, the consideration of its impact on the population and how big that impact was, we were able to kind of understand that we needed to expedite this. There's a lot of money that has to go into this, but more importantly, I think everyone was on the same team in a different way than there's been in the past. Despite what you see in the news, there's people that are in the news, and there's people that are working behind the scenes. And I think it's been very professional of Dr. Fauci, for example, to make sure that without saying it and without being like the administration has been, frankly, he doesn't have to say that. It's what he does as a scientist. It's the population is the consideration, and that's the main difference. Money that's been invested in the population here. I think that's been a fascinating thing with respect to the vaccination and development of the vaccination.
Yeah.
Thank you, Shannon. Thank you so much. Dr. Peck, with regard to the population, what advice would you have for organizations that are having people come back on site, as well as individuals? What do we have to be mindful of to be safer? You know, there's more of a chant for wearing masks. We got that. Is there a particular type of mask? Or just in general, organizations and individuals, what do we need to do in order to be more mindful, to be more safe during this next phase of this pandemic?
I think certainly I think our society is changed forever, and I think forever for good reasons. I think you'll see many more people, even after this quote unquote settles down, wearing masks. I think this is widely accepted in other regions of the world where it's normal and it's natural and it's responsible. I can say, there are many people in our culture, and let's say the North American culture, that look at other things that are happening around the world and they ask, frankly, silly questions because they haven't been in those people's world. They haven't been in those people's situation. They haven't experienced things like COVID-19 pandemic where other regions of the world have. But when you see people wearing masks before COVID-19, of course, in other regions of the world, they're not only wearing masks to protect themselves. they're wearing masks to protect fellow citizens and other members of their society, other members of their population, because there's a different thought process in other regions of the world about protecting your neighbor, and that's cultural. And so with COVID-19, I think I can only hope that we understand what we do as individuals affect everyone around us. And that's something that I think North America is going to be changed forever about. My actions do affect others. Now, wearing a mask is going to be one thing that we do. Social distancing, I think there will be applications of that, certainly with large collections of people. I think, for example, sports arenas will be designed differently. I think we understand that. So social distancing will become part of North American culture. And also, I hope vaccination also becomes a change in our culture. And conspiracy theories, despite what evidence may suggest, conspiracy theories still continue. Now, if something were to happen, and let's say the vaccination is not proven to be effective in the population, then we have to understand why with data, and not just assume that it's some type of conspiracy theory, that this was never a true vaccination from the beginning. And I think that's the other way our society is sort of changing, where we think the better of science, we think the better of persons that are in positions to protect the society, protect North American from destructing itself, and trusting that portion of the workforce. I think that's going to be the other change I can only hope for.
And hopefully there'll be more of a belief in the science, in the research, not just the opinion or a practitioner's story about how he or she perceives it, but to really trust the research and trust the science. Dr. Peck, prior to this year, in my business, I was on the road 65% of the time, in the air, hotels, airports, and so forth. Your thoughts about what that's going to be like in the future for those people who are frequent flyers? Any ideas, any thoughts?
I think the industries in that space will adapt, and they'll adapt through creativity, they'll adapt through innovation. And we see a little bit of that already. And I think we're going to see more of that as things are safer with respect to your risk in the general population. There'll be more innovation to sort of have an inherent thought towards safety with more of the population. The airport, let's call it the travel space, that industry. Yeah. They're going to adapt, and we're going to buy all of that adaptation if it's within our means. But having said that, I think this is important, because I think what COVID-19 in its need for adaptation, innovation, creativity, I think it also is calling for that adaptation, creativity, and innovation in the social responsibility part of all of this as well. To get back to my other point about the population understanding a little bit more about personal responsibility and responsibility toward society, that the industries that stand to profit, of course, there's nothing wrong with them profiting, but as long as they're profiting with social responsibility. And I think that those spaces that you bring up, Dr. James, I think it's going to be safe to travel ultimately, but you will be a different traveler. I think that's going to be part of your personal responsibility, your responsibility toward the people around you, but also you're going to have an easier time doing that because the industry is going to adapt, innovate, and create. And thank God for that, because we may be a healthier society in general because of that, not just from inhalant threats, but also hand touch, in the airport, for example, space with respect to the airport crowdedness, things like that. I think we'll adapt just fine.
Well, your thoughts help reinforce my belief that when people say, I can't wait till things go back to the way they were, they're never going back. We're not going to see that again. It's going to be different. Shannon, your thoughts on that?
I agree, but I am looking forward to a healthier way. And I think if everyone works collaboratively together, like Dr. Peck was saying, we can get there and we'll just have a new normal. But we do have a question. With lockdown and social distancing, mental health has seen its own underlying crisis. And do you see changes in mental health care as we go through the pandemic?
Mental health care it's a great topic. It's a hugely underserved area of healthcare toward our population. Is the feed okay, everybody?
Yeah, sounds
Okay.
good.
Listen, just a personal take on this. I think 2020 has introduced to me for the first time some of the mental health that I'm responsible for personally. I can't say that without this isolation to some degree, social isolation, that we've had to really consider our personal mental health. There's been an unprecedented opportunity to consider oneself, to consider one's life, to consider your interaction with your family, to consider your interaction with your children, and a different interaction with employees. And so we spent so much time at the workplace where that's a type of communication, it's a type of interaction, and we spent little time at home, and that's a certain type of interaction and communication. I think that has flip-flopped. COVID has flip-flopped that phenomenon, which has introduced a lot of mental health considerations to us as individuals and as society as a whole. Now, whether or not you have access, you have a socioeconomic status, you have a color of your skin, you have a cultural understanding or difference, and you have access to then care as a result of realizing some of the mental health that we struggle with, that's a different question. But I think certainly COVID-19 has introduced, at least in my personal story, something about my mental health that I never paid attention to before. But again, I would say that I have the means and the experience in dealing with some of that. There's a large portion of our society that does not have the means and does not have any experience in understanding maybe not what anger is, but instead anxiety. Not understanding what violence is, maybe depression. Those kinds of nuances. And that's what I'm interested in doing with the rest of my life is providing access to a certain portion of the population that is underserved with some of these things that are only considered because people with money and people with means can speak to this to answer your question, Shannon.
Dr. Peck, how did you get on this trajectory? A little bit about your background, how you started moving on this journey?
And which journey is that, Dr. James?
Like what you talked about recently, that's where you see yourself going, moving, working with people more underserved, the inequities that are there. But you can even go back to when you said, I'm going to be a surgeon. I'm going to be a trauma surgeon. And now I'm going to move to a whole new phase.
Yes. So the new phase that I'm talking about is a deeper understanding of the inequities that exist in the care of the population. But my interest in that population has been an interest throughout my life. The interest, to your point specifically, choosing trauma surgery. My understanding of trauma and the population that is trauma was the inner city young African-American youth that was exposed to violence at a very young age. And the reason I chose trauma surgery was because there was a population there of young children that did not choose their path. The path chose them. And so with trauma surgery, that was the population that I knew I would serve. I also knew that that population was a population of lower socioeconomic status that I would serve. And trauma surgeons in general, acute care surgeons, which is a little bit of my background, are surgeons that take care of emergency surgeries, that take care of trauma, and that take care of people that are critically ill with multi-system organ failure in the surgical ICU. But that population that is critically ill, that requires emergency surgery and has an higher incidence of trauma injury is that population that I mentioned, which is a population of color and a population of lower socioeconomic status. So I think underlining my choice to be a trauma surgeon from a technical standpoint, using my hands, being in the operating room, was this other very humanistic part of my choice, which was the population that I would serve ultimately, because I, as others, was a bit of a troubled youth in some sense, and just wanted to connect wanted to connect with that population in caring for them, but also wanting to understand more about the population. And that's what originally set me down the trauma clinical path. Now understanding a little bit more nuanced, that there's data that suggests what my original thought was with a particular population and the patterns in which care was needed to be delivered to them. There's data there to suggest that I was on the right path. And now from a data perspective, trying to drive change so that's not the population we're caring for in the emergency setting, in the trauma, injury, violence, exposure. We're addressing that population way upstream, where their trajectory can be altered by more preventative health, for example, more mental health early in certain populations, in certain settings in the US.
I think you've begun to address my other question, and that was what populations are disparately affected by the COVID-19 pandemic, and how does this provide perspective on other health equity and inequities in the US healthcare system? So you've begun to speak to that. Did you want to add more to it?
Yeah, so where I do most of my critical care is in New Brunswick, and in New Brunswick there is a Mexican American population. Mexican American population, interestingly, of which 90% are from a particular area in Mexico called Oaxaca. We serve a predominantly Latino population in New Brunswick, and the surrounding areas in that county are certainly counties with certain socioeconomic status that we serve at a safety net hospital in New Brunswick. There's no longer any debate. There's data and science that prove this, while controlling for other factors, that the population that has been disparately affected by the COVID-19 pandemic has been the Latino population and the Black population. Now, but the question is not why is that new? It's why is it the same? And what the COVID-19 pandemic has done is it's introduced that concept to everyone, right? So there might have been pockets of healthcare that understood that, or pockets of healthcare that were interested in that, but now everyone understands it, because everyone in some way, shape, or form in the healthcare system, the public healthcare system, the administration, the financiers, the governor, the Department of Health, everyone has been introduced to this idea that, wait a minute, it wasn't just COVID-19 pandemic that the Latino and Black population were disparate with respect to their outcomes, with respect to their access, with respect to the lack of preventative health, not emergency care, right? It's throughout. It's with all healthcare. It's with all healthcare disparities. It's with all health disparities. So now the question becomes, what do we do about it? And who's doing something? And who's doing something about it? And I think there is a good thing about everyone being now aware of what potentially we weren't aware of before. And again, there's another portion of the population that has a good amount of implicit bias where they're still not seeing it. But there's process, trust the process. But we have to leverage what we've learned from the COVID-19 pandemic and apply it to just about every other healthcare disparity and health disparity that we know that the population has, so that we can make some real, we can have some real progress here with respect to equity, and really getting at the root from a data perspective. And in other words, from all of these social determinants of health, to scientists, to clinicians, to financiers, understanding which data points can be put together to say, hey, these are the most common data points that suggest this is why the Black population, and this is why the Latino population and other populations that are underserved are disparate and have inequitable or inequities in their healthcare outcomes. I think it's promising. We're in a good place.
Dr. Peck, what would limit us or others from leveraging the research that shows that there's disparate, things just aren't fair? What would limit that, all that great research and all the momentum that's being built around clarity? What would limit us from leveraging that?
Institutional racism, frankly. There are ways that the systems are set up. And there's a saying that you get out of the system what you've designed the system to do.
Wow.
Right. And so I think there is need for real aggressive, courageous, bold moves toward understanding not institutional racism as a concept, or institutional racism as something that we read about, or institutional racism as something that we see, but instead institutional racism as something that we participate in, right? Personally, we participate in it, right? No matter who you are. And I think that there's a large population that understands they've experienced institutional racism. There's a large population that has participated in institutional racism. And so how do those two populations have a conversation? And that to me is what the money should be invested in, is really getting at helping folks understand their blind spots. And that's going to cost some money, because we're going to have to get creative in the way that we do that, but it's time.
It is time. It is time. Speaking of time, just an aside, it's time for the portion of this show that is called the hot seat. With the hot seat, I'm going to give you a series of words, whether it's one word or two words. And I'd like for you to give the one word that comes to your mind when you hear that word. So one or two words, I'll give you the word, your best one word answer. What comes to mind, your knee-jerk reaction? So the first word is leadership.
Sacrifice.
Safety.
Everyone.
Sacrifice.
Honesty.
Mask.
Safety.
COVID-19.
Hope.
Trust.
Conditional.
Patience.
Needing more.
Medicine.
Responsibility.
Frontline workers.
Congratulations.
Hope.
Reciprocity.
Shannon, pet Dr. P is off the hot seat. Thoughts, reactions?
That was good. Very, very good. I think I want to know very quickly from Dr. Peck is, what will be the first thing you do when the COVID restrictions are lifted?
Take my wife and daughter on a vacation.
That's a great answer.
We're getting close to a nice little reveal. Who might that wife be, Shannon?
Oh, I don't know. I think, she might be in a rectangle right now.
Any other thoughts out there in the chat room for your husband, Dr. Peck?
Folks are just agreeing, saying, thank you for touching on mental health. It's so important. Great answer about institutional racism. And you had mentioned to help folks understand their blind spots, and folks are agreeing with that wholeheartedly.
Good stuff. Good stuff. Do you have one in addition to once the pandemic is over?
Do I have one?
Oh, yeah.
Do I have one? I think I'd like to socialize more, because I think having the option taken away from me made me really take a look at how much I kind of may at times isolate to my own responsibilities and tasks that I need to do. And I think I'm going to be more socially responsible being social, where I'm not going to take it for granted anymore, where you think you could just go see people and it's been taken away. So I think I'm valuing that a lot more.
Thank you. Good stuff. Thank you, Shannon. Dr. Peck, how will you know we've turned the corner? How will you know things are getting better from a way of life standpoint, where there's so much still division in our society? How will you know we've turned some semblance of a corner?
It's a great question, Dr. James. I think it's behavior and how we can measure behavior. I think the way that I'm going to measure behavior that we're turning the corner, and again, this is a point, the population has a responsibility here. We all do with our behavior. Our behavior is going to lead to hospital admission or no hospital admission. And I think once the hospital admissions, and certainly from my perspective, the ICU admissions go down, then there's evidence there that we've turned a corner, and that's reflective of all of our behavior.
Yeah. From a day in and day out standpoint, having been part of this journey this year, back in March and April and May, when we were really into it, places where I would go food shopping, their regulations were, listen, you put your items on the belt and the person behind you cannot do that until you're rung up, and they have to wipe down the belt before the next person can do that. Some of those stores only have one way to come in and one way to leave. They've stopped enforcing that. It's almost as if it's like, okay, we're getting better so we can be more lax. And it's frustrating, because I'm that guy who, if you put your stuff on the belt, when I'm there, I'm going to give you the side eye. I'm going to basically look you into putting your stuff back into your cart. What do we need to do to maintain that focus and not being lax and thinking that things are okay?
I think just not giving up. I think everyone's effort day to day, it adds, it aggregates, if you will. And I think it gets back to thinking not only for yourself, but also thinking for the community you live in. And that community may be, your home that has, 4 people, 5 people, whatever the case may be. It may be your workplace. It may be, your walk up and down your street, whatever the case may be. You're responsible for yourself and also your community. And I think also too, what you're seeing, Dr. James, is also folks that have a very regimented way of going about it, which they have now applied to their daily workings at the supermarket. So I hope that there's a process there that we're not seeing as much anymore, because it's just inherent. But I think also too, you make a great point. The way that we maintain the rigor with safety and the appropriate behavior that is safe behavior is also personally requesting it, and to each other as neighbors say, listen, I would like to just remain socially distanced, and not politicize it, but it's actually a neighbor to a neighbor saying, hey, listen, this is my boundary, and that's how I think we maintain rigor, is really finding it important and communicating it.
Thank you. Question I should have asked early on, and I'm really looking forward to the answer. Is there a difference between a a cloth face mask or a surgical mask or the respirator mask? What are your thoughts? Many of us have the cloth, but I do see some people with those pretty intense respirator-like face.
Yes. So the best way to understand this is it's really scaled. So it's an N100 mask, which is the fully, encompassing mask. The N95, which you see most of the ICU workers wearing, ICU healthcare providers wearing, where it's a thicker cloth. And then you can go down to materials like clothing and then paper masks, which we wear in the operating room. I mean, essentially, if everyone wears a mask, you're protecting yourself and you're protecting your neighbor. And that is as simple as paper masks. There has been some recent data out of Duke that suggests that with certain masks worn down, if one were to sneeze or to breathe or to talk, if masks are loose fitting, then there's some particles that escape. But really how these masks work is that they have a certain density of filtration systems. So the N100, the full mask, it filters the finest, tiniest particles at the highest rate. The paper masks suffice if they're worn correctly, if they fit correctly, if they're not worn to a point where they're wet. And also if you, and if I said it backwards, if I and you, I should say, wear it. So that's another thing to consider too, that the masks are only as safe as the people around you. So that's where this social responsibility, this social pressure, if you will, comes in and is our own social responsibility. The masks differ, but again, the PPE shortage across the US and the world have limited us to everyone wearing the most expensive, the highest filtrating mask anyway. Bottom line is I think everyone wears a mask, everyone wears a paper mask that is a new mask and wears it so it fits.
So these masks prevent the droplets that might be out in the universe that may play a role in us contracting the virus.
Yes, indeed. And the thing to consider is, what is your environment around you? So closed environments, single rooms as opposed to open rooms, rooms with windows open, sitting in the passenger side as opposed to the rear left side, door side of the car. Your closed environment contains the particles, and your masks are essentially trying to filtrate as many particles from escaping you and as many particles from being inhaled. But more importantly, those masks, the paper masks that is, they protect the escape, not necessarily the inhalation or the exposure. So if everyone prevents the escape, then we're all safe as a society. And that's a little nuance in the mask wearing. When I'm wearing a mask, I'm protecting you to a bigger degree than I'm protecting myself at the lower scale masks. When I wear the N100s, I'm protecting me and protecting you to a greater extent. So there's a little nuance there and social responsibility there as well.
Good, that's good. Talking about nuances, there's one more nuance on the show, and we call it the mini keynote, M-I-N-I, keynote. I'm a keynote speaker, I'm a motivational speaker. I talk about a variety of topics, and we've added that element to our show. So we're going to give you 30 seconds as you brush up on your keynote speaking ability and look right at that camera and give us 30 seconds of your best stuff relative to where we've been, where we're going, and what advice you would have for those of you who are sitting on the edge of their seats, attached to the computer, waiting to hear from Dr. Peck right now.
I think in 20 seconds, it's learn to trust the healthcare system. People are on the front lines caring for you and your family. And I think there is a good amount of discussion to distract you from their intentions in being there for you and being there for your health. I think COVID-19 has brought the population together in a lot of ways, and also have brought the healthcare industry as a whole together in a lot of ways. But that is, in fact, dependent on how the population looks at us views us and values us. And we're excited for the future in which the population values us in a new way, so that we are serving the population to the best of our ability. So, and I want to thank all the healthcare workers out there for giving your life, sacrificing your life, frankly. It's not figuratively, it's literally. And thank you for the year that you've served, and thank you for the growth that you have seen in yourself, people around you, and thank you for continuing to move on despite the loss that you might have experienced as well. Thank you.
Phenomenal, phenomenal. Thank you, Dr. Peck. What's next for you? You hinted a little earlier about some of the roads you may take. What's first? What's immediately next for you going forward?
My next short-term dream and intermediate goal is to be funded by the NIH to conduct disparities research. And something else that I'm excited about, and I do want to give a shout out to some degree. I'm excited about Rutgers University's new president, Jonathan Holloway, and I think that's what I'm excited about in the future. That's what's next, is trying to understand that type of leadership and how transformational that type of leadership is going to be for Rutgers University and also for the state of New Jersey and the population that we serve.
Love it, love it. I'm going to look forward to putting my hat in the ring, because I teach for the Rutgers University Executive MBA program. Been working with them since 2009, so I look forward to connecting there as well. Shannon, it's almost time to land the plane. Thoughts?
Oh, we don't want to. I just want to echo, you know what Teresa, one of our guests today, have said. You know what? Thank you, Dr. Smith and Dr. Peck, for a most informative program about COVID. We have these questions about not only COVID, but the vaccine, mental health, etc. Bless you all, and you know what? Very appreciative, and clapping hands. Well said. And again, thank you to all the healthcare workers. So, outstanding presentation.
Well, it's the first time I was on a flight with two Pecks, and we navigated it safely.
Dr. James, can I say something?
Yeah, sure.
I would not have been able to get through this year without my beautiful wife and her undying support and her, at times, unconditional love. And I just wanted to say I appreciate that. I wanted to say that publicly. It's been a bearable, successful year because of you. Thank you so much. And my beautiful daughter, Kennedy, who's just been an exceptional 15-year-old throughout all this. Thank you.
Oh, thank you. Appreciate it.
All right, Dr. Peck, you just created some tissue issues. You know that, right? Thank you for joining us today. We look forward to seeing you next week. Hope you took in the words, the thoughts, the advice that Dr. Peck provided. The video will be up tomorrow on our YouTube. So if you want to check it out again, next week it'll be on our podcast. The book, A Collective Breath, is now out for sale. We talked about that earlier. And Tracy Hunt's book that we talked about yesterday is also out. So please go to those respective websites. But more importantly, or as importantly, stay safe. Consider what was shared. It's up to us to be responsible. If we handle our charge, we create greater possibilities for safety. One more thing to say. You've just been Gym-Pacted. See you next week.